morning, everybody. Thank you very much, Kevin, for the introduction and for having me here today. As Dr. Tucker mentioned, I was trained in Europe, and we are trained to do our ultrasounds ourselves, which I think is a very good asset to have. I'm trying to help change it here in the US too. It's going to take a while. I know there's not a lot of questions on the board on ultrasound, most likely, but I do think if they come up, I want to give you a few hints how to interpret images. Secondly, I think it's important to actually have the skill of at least looking at the pictures that the radiologist will obtain for you and kind of interpret or get your own impression on the kidney disease or the vascular disease in your patients that you see in your clinic or in the hospital. I have no disclosures, and I would like to start with a case of a 24-year-old young patient who presented recently to the hospital. She was a short little lady. She had no past medical history, and she had a sudden onset of swelling and discomfort in her legs. She had a period of nausea and vomiting 2 weeks before this episode. Her blood pressure was a little bit on the high side at 136/89. Her heart rate, 88. She was afebrile. She had no distress. She had a weight gain of 15 pounds. Regular heart rate, no. Lung exam was normal. Abdominal exam was normal. And it looked like trace extremity edema, lower extremity edema. Her sodium was low at 130, potassium 5.1, creatinine was 3.6. That was surprising. The GFR was 15, bicarbonate is 20, and the UA showed red blood cells and some white blood cells and 1+ protein. And I'll let you take a look at the images here. I'm not sure how familiar you are with that, but give it a try. So you have the right kidney on this side. It's a longitudinal cut, the left kidney on this side with a transverse cut. Here's the size of the kidney, 11.6. And the questions for you would be, do we have a normal-sized kidney without evidence of hydronephrosis on the right? Do we have normal-sized kidneys with evidence of hydronephrosis on the right? Do we have normal-sized kidneys with cysts? Small kidneys without evidence of hydronephrosis? Small kidneys with evidence of hydronephrosis? You want to take another look? And then make your choices. Does it work? No? So you need to know two things: size of the kidneys, what is normal, and then if you look at the picture, was there anything that lets you think about more fluid like cysts or hydro in one of those pictures? I can put them back for you. Oh, seems to be working now. Ooh, seems to be difficult, right? I'm happy. I'm hoping I'm going to give you a few hints here to kind of be able to interpret the data. All right, so majority, we have no majority. We have B and C kind of being the same, normal-sized kidneys. So I think that's already a good thing. And then the question, is there hydro? Normal-sized kidneys with evidence of hydro on the right, normal-sized kidney with cyst on the right, or normal-sized kidney without evidence of hydro? Well, the correct answer is actually normal-sized kidneys and no hydronephrosis and no cysts. But you see something there, which is kind of throwing you off, right? All right, so let's see what it is. All right, let's try to think about ultrasound and what it actually does and mean. You have an ultrasound machine with a probe that has crystals in the ultrasound probe. They are emitted into the body. It's a mechanical wave. It will hit on structures in your body and then will be reflected, absorbed, or scattered. So if a wave hits a structure that will absorb everything, it will be depicted black. That's usually fluid. If it hits something that reflects everything back, it's something that has a high density, and it is usually bone or stone. And scattering or refraction of the wave will produce an image that has different shades of gray. So B mode shows you different brightnesses, bright, black, and different grays. Therefore, the words that are used in describing those images will be something like anechoic, which is black. Remember, that is fluid. Something that is hyperechoic on the other side will have a high intensity signal. It is calcification or is fat. And words like hyperechoic and isoechoic will be used to describe structures in comparison to each other. So we will use those words for describing the echogenicity of the liver or the kidney. Sorry? There's two phenomena or artifacts that I would like to point out to you at this point, and one is something called dorsal enhancement that you will find if you have a fluid-filled structure. It will have an increased intensity signal behind it, so that's a classical sign for a cyst. And then there's something called shadowing, which is the extinction of the signal, which you will see behind a structure that reflects everything. Those are stones and bones. So remember echogenicity, anechoic, hyperechoic, and these two artifacts. And then just to remind you of the kidney anatomy, we have the parenchyma that consists of the cortex and the medulla. That's more medial. And the medulla has these structures that are the pyramids. They're kind of like triangular shaped. You have the pelvis and the calyces on this side, and you have vessels in the ureter that you usually don't really see on B mode ultrasound unless there is something wrong. When you look at an ultrasound of the kidneys, you will always have two planes. One is a longitudinal cut, where you have the kidney in its length, where on the left side of the picture is the cranial part of it's cranial in the patient, on the right side it's caudal, and in a transverse cut, you will have the right side of the patient on the left of your image, just like in CT imaging. This is anterior, this is the front of the patient, and this is posterior. So here you see the liver, the kidney, the size of the kidney. You see the increased echogenicity, which is the sinus fat. You may see these darker structures right there. Okay. And what are those structures? Now that you looked at the anatomy, they are in a typical location for the pyramids. So the pyramids are usually a little bit less echogenic than the rest of the kidney. So that maybe made you mistake them for cysts or hydronephrosis. So the next thing to think of is the size of the kidney. And what's normal, 10 to 12 centimeters is the normal size. You kind of have to adjust that a little bit to the size of the patient. And next to just looking for the kidney, if it's present or not, the size measurement will give you hints for structural changes like scarring. If you have a smaller kidney, which is smaller, what is pathological is if the difference is more than 1 centimeter, it will tell you that this kidney has scarring, which will classify the patient into CKD stage. And do you know what it is from? No, you don't. It can be a vascular, postpyelonephritic, or post-obstruction. And the size does not tell you anything about the function of the kidney. So if you have a small kidney on the one side, you can have big kidneys on the other side. And there's two states of hyperfiltration, like diabetes and preeclampsia, where you'll have a size increase of the kidneys of 12 to 13 centimeters. And then there's infiltrative disease, like multiple myeloma and amyloid or lymphoma, or acute GN and AIN or venous congestion can lead to an increased size of the kidney. Okay, let's talk about echogenicity. Not sure if you can detect the kidney right here, but if you remember, this is the liver, and right underneath it you have a structure that reminds you of the kidney. It looks different. It's much more echogenic than the liver, so this is increased echogenicity. Again, you see those black spots, which are the pyramids, which are much more pronounced because this is more echogenic. There it is. It's big, and the sinus fat, and the pyramids. This is not a cyst, and this is not hydro. And if you look at this picture, it's kind of like the inverse of what we were just seeing. You have the liver here, the cortex, which is hypoechoic as compared to the rest, and then the structures that we were seeing here that were less echogenic, they are hyperechoic. So what could that be? Calcification, nephrocalcinosis. That is right. So this is how you can train your eye to actually look for the echogenicity, the size, the presence of the kidney. And in our patients, those little round structures that you thought were cysts or hydro, they were basically the pyramids that were more pronounced in a patient with acute kidney injury from a GN. So the kidney size was normal, and there was no hydro and no cyst. All right, let's take a look at our next case. And that's a 57-year-old man with a 5-day history of flank pain, worst pain ever, associated with nausea and vomiting. So you automatically think this must be a kidney stone, right? But blood pressure is normal, heart rate is high, the temperature is 99.5, he's in distress. He has slight tenderness on the right of his abdomen. His creatinine is 2.3, so that's kind of surprising. B1 is 57, GFR is 32, potassium is 3.8, UA shows red blood cells and some white blood cells. What is the image of your choice that you would like to have in this patient? The options are CT angiogram with contrast, CT urogram with contrast, renal ultrasound and a KUB, renal ultrasound with color and Doppler, nuclear scan with furosemide. Take your pick. Excellent. That's very good. So obviously nobody wanted to take anything with contrast, right? GFR of 20, I would stay away from it. Very good. Do an ultrasound. Perfect. Non-invasive, non-toxic. You don't need contrast. It's easily done. But you chose something else in addition to that, which is a KUB. Because you're thinking, well, there may be a stone, so you want to see calcifications, which may not be necessarily always be found in ultrasound. And then maybe later you would think about Doppler, if there's anything you think about the vasculature, or a nuclear scan with furosemide. So just to point out that the American College of Radiology appropriateness criteria tell you that in a patient with flank pain, if you can, you would do a CT scan with and without contrast, which we couldn't do in our patient. Do an ultrasound, but then add either a KUB or a CT scan without contrast to look for those small stones that may or may not be located in the kidney or may be located farther distal. All right, and now you have the ultrasound, and you see these pictures. Right kidney, left kidney. Remember what I told you about parenchyma, echogenicity, where are the changes in echogenicity, and then pick. Do we have normal kidneys? Do we have normal kidney on the right and cysts on the left? Do we have a normal kidney on the left and hydronephrosis on the right? Do we have hydronephrosis on the right and the left? Or do we have hydronephrosis on the right and cysts on the left? I'd like to take another look. All right, so E, majority is for E. I can just take it out. Hydronephrosis on the right and cyst on the left. I don't blame you for that answer. I can see why you picked it, but it's actually hydronephrosis on both sides. Okay, and I'll show you why that is. So how does hydronephrosis look like? Well, you see a kidney here. This is the parenchyma, the sinus fat, and then there are black areas that are in the medial part of the kidneys with this triangular shape that kind of extends in this area, and those are the calyces that are mildly dilated. So this is a picture for mild hydronephrosis. Now, this is a picture of moderate hydronephrosis, and this is what I used for the case. How is moderate defined? It is defined by this, again, we have this triangular black area here in the medial part of the kidneys, and then it looks like a bear paw. Just remember that as a picture, bear paw. If you see that, then that's hydronephrosis. The calyces are quite wide, and on the transverse cut, this can look sometimes like a cyst, but it goes into your calyces, so that's why this is hydronephrosis and not a cyst. And this is how it looks when it's severe. It becomes very difficult actually to see kidney, and you'll see just big patchy areas of black. And some ultrasound is 100% sensitive for hydronephrosis of moderate and severe degree. These are the different gradings. You go either by mild, moderate, or severe, or grade 1 to 4. And just as in comparison to that, the cysts are not so often located on the medial part of the kidney, but more in the periphery of the kidney. They're very, most of them have a clear margin. There's different type of cysts, which you obviously know, but this is a simple cyst, and it has this dorsal enhancement. Remember that artifact that I was telling you about at the beginning? This is a classical criteria for a cyst. So the location, the shape, and the additional artifact tells you this is a cyst and not hydronephrosis. What will really tell you everything about the collecting duct system? It would be a CT urogram with contrast. Obviously, you don't choose this if the patient has decreased kidney function, but what you could do is if you have someone with hydronephrosis and you do need to look at the ureters, is have percutaneous nephrostomy tubes placed and then apply contrast, which is distillate to the glomeruli, so that will not affect the kidney function. It's a very nice way to get a urogram without having the patient being exposed to contrast. Now, hydronephrosis is not the same thing as obstruction. You can see hydro and have no obstruction, and you can not see hydro and have obstruction. So that's actually the difficult case. And I think the main message is to remember that because frequently the urologist will say, well, there's no hydro there, or it's really not impressive, I'm not going to do anything about it. But you say, well, but I do, so you have to prove that this is actually obstruction, and he needs to put stents or splints in there to actually relieve the kidney, because the patient has acute kidney injury, is not making urine. You don't really want to dialyze him if you have the option of relieving hydronephrosis. So the false negative findings you will find are in retroperitoneal fibrosis, prerenal states with low volume, and early and sudden obstruction. On the other side, you will have impressive pictures of hydronephrosis in patients which have reflux or megacystic megaureter syndrome. They don't really have a kidney dysfunction and don't have obstruction, or patients with brisk diuresis and nephrogenic DI. And how can you actually prove that somebody has obstruction? What's the imaging of choice in this situation? LASIK scan. That is absolutely correct. Yes, that's the indication to do a nuclear scan. There's basically two of them. You can add captopril scintigraphy, which I won't talk about it today. But one of the main indications why we would want a nuclear scan with addition of Lasix is to prove obstruction, urodynamic significant obstruction. Very good. And then let's look at how would a stone look like. Remember, stones, if they are calcium containing, which the majority will have, they will have a high intensity signal, and they will have the artifact of shadowing, which you see here. So these are 3 kidney stones with extension of the signal behind them. The best method, though, especially if you look for stones outside of the kidneys and very small stones, would be a non-contrast CT. So in summary, the role of B mode ultrasound is to see at the size and the aspect of the kidneys, look for hydro, detect polycystic kidney disease, bladder size, post-void residuals, fluid collections, stones. You can look for masses and cysts. You can look for everything, and you can use it for ultrasound guidance for biopsies. And I think, and it should be part of everyone's protocol, to have an ultrasound in any patient who has kidney disease, acute or chronic. You can use ultrasound in transplant patients for the same indications. In transplant patients, I think it's particularly important to do serial exams because you have frequent changes, especially early in the course of the transplantation. All right, and then let's look at our third case, which is a 77-year-old female who has stage 3 CKD, hypertension, hyperlipidemia. She had radiation and had Lariche syndrome, which is a distal aortic obstruction, spinal fusion, after which she had many infectious complications with a lot of antibiotics. And she comes to your clinic complaining of edema. Her creatinine over the last few months kind of increased from 1.1 to 1.3, 1.8, and 2.0. The blood pressure is controlled with one medication, metoprolol. Well, maybe it's not quite well controlled. Her blood pressure was 185/79. She's quite tiny. Blood pressure is a little bit better after 5 minutes. She has signs of volume overload. Creatinine is 2.1, the GFR is 22, and UA is quite unimpressive with minimal proteinuria. And you obtain an ultrasound where the right kidney is 9.4 centimeters, and on the left side it's 8. So there's a side-to-side difference. There's no post-void residual. We have a question here. What would be the next appropriate step in the diagnostic for worsening renal function in this patient? Nuclear scan for determination of differential renal function, Doppler ultrasound for evaluation of renal artery stenosis, CT scan for detection of stones or masses, an MR to detect stones or masses, CT scan for detection of bilateral renal vein thrombosis. Please select now. Excellent. I like your choice. So, Doppler ultrasound for evaluation of renal artery stenosis. Now, it may be controversial if to intervene or not, and that's nothing I'm going to talk about today, but I think it makes perfectly sense in this patient with bland sediment, slowly creeping up creatinine, history of vascular disease, to actually look for the kidney perfusion. Even if you don't want to do anything about it, I think it's important to have the diagnosis and to understand what's going on. Now, let's look at pictures, and for that I would like to review the anatomy of the vessels, and just to remind you that the renal arteries take off at the same level as a superior mesenteric artery. On a transverse cut, you may be seeing this on a CT scan. You look for the spine, the aorta, the IVC, and where the SMA is, there would be the offspring of the right and left renal artery. And similar on the ultrasound, you look very high up in the epigastrium within a transverse cut and obtain this image where you have the liver first, the spine here with extinction, the aorta and the IVC. This is the SMA. And then the right kidney would be here, the left kidney would be here. And you do need to look hard for a structure that is 5 to 6 millimeter wide and have good machines to do that, especially if the patient is very heavy. But about 10 o'clock or at 4 o'clock, you would have the offspring of the right and the left renal artery. In these situations, you do apply color to actually see the vessels more by the blood flow that is represented there. And just to remind you, color Doppler shows you directions and not like red is coding for usually flow towards the probe, blue flow away of the probe. It's not telling you artery or vein, it's just the flow direction. And this is how you see the aorta with the right renal artery first going a little bit up towards the probe. That's why it's red, and then it becomes blue. And this is the left renal artery, which is typically blue. Now, what happens if you have a stenosis? The Bernoulli formula will tell you that the product between the velocity here and the area here has to be the same as velocity and area here. So if the area is much smaller here, the velocity has to increase. Therefore, in a stenosis, in the stenosis itself, you'll have an increase in flow velocity. And that's true for any vascular bed. An increase in flow velocity will tell you stenosis. And the criteria for stenosis is 200 centimeters per second for a 60-degree stenosis. Here's the spectral Doppler with about 200 centimeters per second, so maybe there's a 60% stenosis. And on this side, flow velocity is 456 centimeters per second. That's a high-grade stenosis. Now, you have all heard about the so-called resistance index, and it's kind of confusing for most of you. And one thing I want to point out is that resistance index is a measurement done in intrarenal vessels, so not at the site of the stenosis, behind the stenosis or in the kidney. It is a spectral Doppler showing the systolic and diastolic flow, of which the index tells you something about the relationship between systolic and diastolic velocity. There's a normal range, though you have to know a lot about the normal range because there's much variation. Two things: resistance index can be high, that is either due to stiff vessels, age, atherosclerotic disease, or intrarenal changes with decreased invascular bed, or it can be decreased, and that's post-renal artery stenosis. So in renal artery stenosis, low resistance indexes can be expected. And why is that? I will just want you to show you the change with, if you have a stenosis in the vessel, in the kidney, you'll have flow spectrum that look like this. And you remember pulsus parvus and tardus from aortic stenosis. What happens? The amplitude is dampened, the acceleration time is prolonged. So whenever you will hear pulsus parvus and tardus in a description in your kidney, then it means that there must be a stenosis on the way to the kidney, which would typically be, most likely be the renal artery stenosis. So low resistance index, pulsus parvus and tardus, look for those to indicate high-grade or irrelevant stenosis. And now, a difference between US and Europe is what criteria do we use? You will mostly get the flow velocity numbers as an indicator for renal artery stenosis. There are several studies that have mainly been done in Germany, yes, and in Europe is the combination of the two criteria, direct flow criteria plus side-to-side comparison of resistance index. And this, on this side, this is a pulsus parvus and tardus. This indicates there must be a stenosis on that side. You have the alternative of doing a CT angiogram, which gives you very nice pictures, high sensitivity and specificity. Of course, you need to use dye, a lot of dye, or MRs, where you use gadolinium. Very good sensitivity and specificity. Again, we need to use gadolinium, which may be toxic. You need to know that there's options of non-contrast MRs with a special technique. This shown in a study of on kidney transplant patients, where this is the MR, non-contrast MR of the patient with a renal artery stenosis, or this image of one of our patients at the hospital with MIP, maximal intensity projection from the source. So very nice images if you can do this. Use color and Doppler in transplant patients, and this is something that maybe I would like you to take along. Is if you see the spectrum in a patient with a kidney transplant where there's no diastolic flow or negative diastolic flow, this is pathognomonic for a renal vein thrombosis. There's no blood flow going to the kidney. So those are the benefits of ultrasound with color and Doppler, especially good for renal artery stenosis. Transplant perfusions, AV fistulas can be detected like that, and transplant renal vein thrombosis. And in summary, I would like to point out the ultrasound with B Mode, color and Doppler is inexpensive, non-invasive, non-toxic, and easy to repeat. Everybody says it's operator dependent, but everything is operator and interpreter dependent. If you ever take a CT scan to 2 different radiologists, you may get 2 different answers. So be aware of that. You can do nice CT imaging, which is very helpful, especially if you want to do reconstructions, if you can do it, and renal toxicity is not a problem. MRIs and MRAs are very helpful for tumor vascular imaging. Again, GFR below 30 can be a problem. And the take-home messages overall is that I think every patient with kidney and vascular disease should have a renal ultrasound. It is non-invasive, non-toxic, easily repeated. I do hope you will look at the images yourself and try to get your own impression on what people are telling you is going on. Look into doing the ultrasound yourself if you can, if you have a chance to do that. And of course, there are many different techniques that have their strengths, and you just need to be aware of the strengths and weaknesses of every single method, and maybe you need to use different methods to actually get to your diagnosis. And I think that's the end of my talk. I'm happy to take questions.